Yakov, thank you so much for that. It's fascinating seeing the basic science side part of what we're seeing in clinic. And so I really appreciate having the chance to hear you speak. And my goal today is to talk about radiation for neuroendocrine. And I think that this talk is going to be more aspirational than informative, because in my opinion, I think that radiation is really in its infancy in this disease. And that is what I want to be the crux of the conversation, is what is the role that radiation in its different forms have in this malignancy. These are my disclosures. I do have research funding from CNET as well as Ipsen and AAA Novartis. So as Yakov's laid out, neuroendocrine tumors are incredibly heterogeneous. They're found all the way along the digestive tract, and they really have variability with respect to how they behave and subsequently how we manage them. And so from a clinical perspective, what's very important is to determine which ones are functional or secretory versus not. Because in addition to having to manage the implications of having disease, whether it be localized or metastatic, there's also the questions surrounding hormonal excess and the end organ damage and impact on quality of life that it has for patients. And so it really does provide a challenge for the clinicians treating this, because we have to manage those components as well. And as Yakov was also reiterated, we're seeing the incidence go up. The detection is better. Certainly there's improved classification of these diseases, but we are seeing increasing numbers globally. And so this tumor, which we used to call rare, is not rare. We now call it uncommon. So when a patient comes to clinic, this is really the algorithm that we will be looking at in determining how we will treat them. And again, it's going to be dependent a lot on the functional status of the patient, but then also on their clinical presentation. And at each point in their journey, we're always reevaluating what treatment will be best served for these patients, because quite uniquely, especially within the lower grade tumors, is the fact that the life expectancy, even with metastatic disease, can be incredibly long, upwards in decades with metastatic cancer, which is very unusual for most malignancies. And so not only do we need to worry about now the functional status, we need to worry about disease control, but also the timing of therapy, because we need to ensure that we are maintaining patient quality of life, again, through each aspect of their care. And I really want to focus today on two components, really the ablative side of things, and then ultimately systemic radiation treatment. So when we traditionally think about ablative therapy for neuroendocrine, it's typically going to be things like RFA or transarterial embolization. And part of that is due to a historic view that neuroendocrine tumors are radioresistant and it doesn't work. And in fact, one of the most cited studies to state that comes from U of T. It's a paper that was done by Bernie Cummings many years ago, where they looked at whole abdomen radiation for patients with carcinoid. And not surprisingly, they found that they had poor results. And it led to this cascade of subsequent opinions and papers saying that it doesn't work. And that's not surprising. Using low-dose radiotherapy for this type of metastatic disease, you wouldn't expect to have high impact. But we're moving into an era where that kind of radiation would never be appropriate. And stereotactic body radiation therapy, or SBRT, is now being used across multiple sites. So, started predominantly in the CNS, but now moved to other solid tumors and now into metastatic disease. And we know that using this high-dose, highly conformal treatment is effective across tumor sites. And so the question is, why not neuroendocrine? And in fact, it's predicted to work. This gene expression model looking at potential radiosensitivity actually shows that small bowel neuroendocrine would be predicted to be amongst the most radiosensitive, with colorectal and pancreas really being in the same range as colorectal, which we would say would be the paradigm for most patients treated for the liver. So with this understanding, but also with me coming on board in the Susan Leslie Clinic, we really expanded the role and use of radiosurgery for our patients. Now remember, these are quite often going to be on systemic therapy and likely to develop oligoprogressive disease. And so we started a program really to try to push or promote our treatment. And this was published last year in Neuroendocrinology. Now, admittedly, these are low numbers. So 53 metastases in 25 patients. However, this is by far the largest series in the world. And really, for me, it's proof of concept or proof of principle that the radiotherapy is an effective treatment. When you look at per lesion local control, it's 92% in a year. Interestingly, the overall response rate of 32%, which is good if you look at treatment of liver metastases broadly, what's interesting in neuroendocrine is overall response has never really been found to have an impact on progression-free or overall survival. And so we think it's interesting that we were seeing response, but generally speaking, that doesn't translate into PFS. Importantly, there were no grade 3-4 adverse events seen in our series. So again, demonstrating that the therapy can be delivered, it can be delivered safely and effectively. But how do we further this role of radiation? And as mentioned, these patients will have long trajectories, and to maintain them on systemic therapy, which is effective, is a very important goal. And given the fact that there are limited options, Iakavos mentioned that we've got somatostatin analogs, the backbone of treatment. But really, when it comes to other systemic therapies, we've got everolimus and Sutent. So really, we've got 3 drugs that are used for grade 1, grade 2 neuroendocrine tumors. So we really need to improve the lifespan of those treatments. And so from that was devised the OZM-057 clinical trial. Now, this was an open label prospective study looking at the combination of everolimus and liver radiotherapy. And this was really to be a proof of concept that the 2 treatments could be delivered together. And I think it's important also to note that this trial was developed before the availability of PRRT, which I'm going to speak to towards the end of the talk. So this is our study schema in which patients were identified and they were treated initially with upfront everolimus. They were then treated with concurrent everolimus and radiotherapy, followed by another month of everolimus. We built into this both imaging and lab biomarkers, as well as long-term follow-up and quality of life assessment. And the results from this were published in ERC last year as well. So 14 patients were treated on this pilot study to a total of 40 metastases. Response rate 38%. And I think what I thought was the most interesting was the time to maximal response was 8 months. Again, likely reflective of the slow growth of these tumors. Median overall survival is 92%. Again, not surprising given this malignancy. But what I thought was the most important finding was that the median time to change in therapy was almost 2 years. So by utilizing SBRT on top of, for oligoprogressive disease, we are able to extend the lifespan of systemic treatments. So why is it so challenging treating this cancer? So, I talked about it being clinically heterogeneous, and Iakavos beautifully outlined how biologically heterogeneous these are. So there are very few changes that are seen in the genome. We note that there is very heterogeneous expression of PD-L1, and this is really associated with grade, that for grade 1 and early grade 2 NETs, only about 30% will express PD-L1 overexpression or tumor-infiltrating lymphocytes. And then finally, there are very few predictive biomarkers. The presence of mTOR is in a small proportion of patients, and we do note that MGMT hypermethylation can reduce the impact of temozolomide, and that is very important because for higher grade pancreas neuroendocrine, capecitabine and temozolomide would be a standard of care treatment. And getting back to this idea of this being a immune desert, this was work done by Ben Lawrence, who's a colleague through the ComNets group that we work with. really showing that pancreas neuroendocrine tumors have exceedingly low rates of mutation. Why is this important? Because we know that mutation number is associated with the response to immunotherapy. And the fact that they have low mutation numbers bears out with the results of the trials. To the right, these are results from NET 00102. This was a study that was led by Simran and David Chan, our fellow at the time, that was looking at avelumab, so PD-L1 inhibitor for both grade 2-3 neuroendocrine neoplasm as well as grade 3 NECs. And really the results were very disappointing, that PFS was only 3 months with overall survival just over a year. And you can see on the bottom the response rates that very few patients actually demonstrated an overall response. This is in line with what was seen in Keynote using pembrolizumab, where an overall response rate of only 6 to 12% was seen, as well as the Elevation study looking at atezo, which showed response rates less than 20%. So monoimmunotherapy to date has been incredibly disappointing. There was one basket study through SWOG where they looked at CTLA-4 anti-PD-L1 therapy, which showed in high-grade NETs that there was a 44% overall response rate, which is somewhat increased interest in combination therapy. But as noted to date, really disappointing, and it's something that our patient groups are still looking at us to try to find mechanisms in order to expand and extend the role of immunotherapy to these patients. So is there a further role for SABR in these patients? Well, it's a question about, can other modalities upregulate the immune response? And we note that radiotherapy has shown upregulation of PD-L1 expression in sarcoma and rectal cancer, both typically seen to have less mutations than other malignancies. And so we extended that to, is there a role for neuroendocrine? And so Sabirio was a concept which was combining SABR to multiple sites of disease with PD-L1 inhibition for patients with high-risk neuroendocrine tumors or carcinomas. It was presented at the COMNETS clinical trial group. It received high score for development. We had industry ready to go. We were ready to activate, and then they pulled funding. And so this got put on the wayside. And so when we revisited at the COMNETS group, we looked at smaller pilot studies to gather data. And so this is now SABRNet. So SABRNet is two components. It is a prospective study looking at the role of SBRT for these patients. But with that is a correlative study in 15 patients where we're trying to understand the immune environment changes in response to standard of care SABR. And so work with our colleagues from pathology, we're evaluating tumor infiltrating lymphocyte PD-L1 expression, as well as other markers. And in collaboration with Stan Liu's lab, as well as my former colleagues at NIH, we're looking at multiplex cytokine array, as well as flow cytometry to see whether or not radiotherapy can impact immune cell expression. So that's on the go. And it's really looking at this holy grail of abscopal effect and influencing immune response. I think it's provocative, and it's certainly early stages, but it's something that I'm quite interested in. But now I'm going to change roles completely and talk about something which is much more mainstream and I think much more relevant in terms of how we can look at precision and collaborative care. And this is radioligand therapy and theranostics. So the concept of theranostics is using a cell-specific marker linked to an isotope which can be used for imaging and subsequent therapy. And this is a really hot topic in oncology right now, and neuroendocrine tumors have really provided the paradigm for this idea. And this has been around since the 90s. This treatment was initially started in Europe, and it has really spread across the globe. And it's based upon the fact that neuroendocrine tumors will typically overexpress SSTR2. And so this provides a target for both imaging and therapy. And how this evolved, initially we would do octreotide scans, so using the 111 indium scan. But now modern imaging is using the gallium-68 DOTATOC PET. And so a linker molecule attaches a gallium-68 molecule, which circulates and will attach to the target SSTR2 receptor. And why is this important? It gives us incredible information in terms of management of these patients. Number one is localization of disease. It is certainly the most specific and sensitive imaging modality we have to understand extent of disease. And this has implications with respect to the idea of upfront surgery, cytoreduction, or other systemic therapy. More importantly, it will predict the behavior of disease. As these tumors become more dedifferentiated, they lose the somatostatin receptor. And so the combination of gallium-68, we'll talk about later with FDG-PET, can predict for more aggressive behavior. And finally, you need to have the presence of this receptor to predict response to PRT. And so these three components are answered using the gallium-68. So where do we go from there? Well, if we have a target, then we can treat. And the initial radioligand therapy was Y90. And subsequently, more globally, we're using lutetium-177. And that is currently what is approved in Canada today by Health Canada for standard of care therapy. And that approval is based on the NETTER-1 clinical trial. So this was a study that was randomizing patients to PRRT versus dose-escalated somatostatin analog therapy. Now, these patients must have already failed on SSA, and they must be inoperable, with the primary endpoint being PFS. PFS as an endpoint in neuroendocrine trials is an important concept because we know that, again, given the long runway of these patients, that sometimes overall survival trials are not reasonable or feasible. And so based on the NIH guidelines, PFS is the preferred endpoint for these patients. And really it showed dramatic responses that in comparison to dose-escalated somatostatin analog, the PFS at 20 months was remarkably different, again, with a very modest response rate. And this was across all groups that were in the trial. Now, when they did the final analysis looking at overall survival, it was not significant. You know, the absolute numbers, it was a 12-month difference. And part of that was due to the fact that this study allowed for crossover. And so patients that had failed on the dose-escalated arm were allowed to cross over to PRT, and it's likely that that has muddied the waters. If you remove the crossover effect, then the control arm survival is only 30.6 months. The adverse events, again, quite favorable. Interestingly, in the somatostatin analog arm, tumor-related events typically were the grade 3-4 adverse events. Within the PRT arm, it was either related to nausea, vomiting during treatment, or secondary to transient lymphopenia. We do need to be cautious about this therapy, however, as it is documented that there is a risk of development of either MDS or secondary malignancy, namely leukemia. And that rate is at 1.8 to 2% per year, or sorry, 1.8 to 2% per lifetime. And I'd be remiss to say that we have seen these patients, and unfortunately, these leukemias are very aggressive and they die shortly after developing it. Quality of life was a huge component of the study. And what it showed was that, again, PRRT was associated with stability or reduction in the time to deterioration for these patients. And so across all domains, PRRT maintained patients' quality of life better than other therapy. So based upon these results, this is now Health Canada approved, and it's now standard of care for mid-gut patients who have progressive disease post-SSA. But where are we going? You know, as I mentioned, the historic challenge with neuroendocrine tumors has been the timing of therapy. And, you know, our standard paradigm would be do the least invasive first and then escalate afterwards. But NETTER-1 told us that more aggressive therapy actually improved stability of quality of life. And so this set the stage for an upfront trial, and this is NETTER-2. So NETTER-2 is a study for patients with newly diagnosed unresectable metastatic grade 2 or 3 neuroendocrine tumor. And it is, again, randomizing from PRT versus upfront dose-escalated somatostatin analog. And Sunnybrook has a lead role in this. We are the global lead, so Simron is the global lead of the study. And at present, we also have the largest global accrual. And so we are really leading the way in the world with this therapy for these patients. What else is exciting is that NetRetreat has now gone through the NCI GI Steering Committee and CCTG. And so NE1 is the first randomized study looking at retreatment PRT for patients who have had stability post-PRT. And so again, Simran is the PI on that study, and I'm the RAD-ONC lead for it. But where else are we going? So lutetium and Y90 are both beta emitters. There are new isotopes which are under investigation for neuroendocrine tumors. And the idea of using alpha particles is gaining a lot of interest because of the higher LET and shorter penetration in tissue. So actinium-225 dotatate has been studied in multiple small trials, the largest of the small being 32 patients, showing safety and a really impressive response rate compared to the lutetium-177. And so we are in the late stages of joining a randomized phase 2-3 study evaluating this. So, another complement to our already growing stable of isotope therapy. So what else has come through the NCI CTPM, or the Clinical Trials Planning Meeting? So the first is PRT immunotherapy. There are some early phase 1-2 studies which are going to read out in the next year. And NCI CTPM is already planning on moving forward with combination therapy in the event that those studies show safety. Individualized dosimetry is a huge component where, rather than do a one-size-fits-all for treatments for patients, we're going to look at what is the absorbed dose to target sites and use dosimetry to better deliver tailored dose. Should we give more cycles? Should we do something to boost those patients that don't get these high absorbed doses? And then finally, our group through the PRT LDT committee is, can local therapy accentuate the response to PRT? And can we address the heterogeneous nature of it? So part of that is looking again at imaging biomarkers. So this is work done by David Chan, who is a former fellow of ours who's now in Australia, where they were looking at characteristics of both FTG and gallium-68 to provide guidance of best therapy for patients in the PRT era. And what we want to do is use this guideline to help identify those patients that still may benefit from PRT, but give subsequent therapy which may boost its impact. The Australians have looked at this with combination of PRT and capecitabine-temozolomide chemotherapy. And it has not read out in its final publication, but at ASCO 2 years ago, the results came out in the mid-gut patients, which were very disappointing. That there was great tumor response rate, but unfortunately no improvement in PFS with increased adverse events likely related to the hematologic component of the chemotherapy. And so this has really been abandoned at this point in terms of combined therapy. And so the trial concept that was presented and what we are working on is actually coming full circle. Can we add SBRT to PRT? And can we use the imaging to highlight those areas at greater risk of failure and supplement PRT with external beam radiation therapy? And so the concept would be, again, select the patients based upon the gallium and the FDG PET characteristics and utilizing PRT with focused SBRT to supplement those locations. So this was presented again at CTPM, and it was an area felt to be of interest for development. And so this is kind of my baby with the LDT group. But again, I think there were some concerns about how early the data is for SBRT in this disease and limited data with respect to combined therapy. And so we're again moving into more pilot studies to provide the predicate information to advance this idea. And I'm cognizant of time, but Bob, I'll be done soon. How much time do I have?
Oh, you're muted. It's just
we're at 6:30 now, so not much time.
All right, I'm going to skip ahead to a couple of slides then, just to say that this treatment is coming. And it's not just neuroendocrine, in which radioligand therapy is going to become a new standard. We know with prostate cancer that PSMA lutetium has been shown to have effectiveness and has now been FDA approved as of a few weeks ago. And so we are facing a huge challenge with respect to capacity. This is data for what is expected to be the utilization in Ontario for radioligand therapy over the next 10 years, going from 0 patients in 2015 to over 2,000 in 2035. And this mirrors what we've seen in our own practice, where 2017, when the program started, we were treating 8 patients per year. 2021, we got approval for Lutathera in the province. And you can see how those numbers have escalated dramatically in terms of the treatments we're delivering. And 2022, we're on track to eclipse what we've done beforehand. And so I really caution the group that this is coming. And I really think that we need to think about these vertical integration of the things that Yakovos was talking about how we're going to have this incredible wealth of patients who are being treated, and how are we going to integrate that kind of science with this kind of therapy. So again, summaries, the opportunities, as Yakov said, are endless. Net specific, huge clinical base and huge interest in the basic science as well as the clinical research programs. Our radioligand program is really world recognized, and it's only going to get bigger. Our basic science team is incredible. And we can't forget that we have an in-house cyclotron. So Isologic is in Sunnybrook. People don't know this. We have a cyclotron here, and there's opportunities for research and commercialization within our own center. And so with that, thank you for indulging me over time.